Hey guys, thank you all for having joined today. And so let's just get going. I just wanted to take a minute to introduce the speakers and the panelists. I mean, of course, Dr. Praveen Chandra needs no introduction. One of the leading cardiologists in India, if not globally, and also the chairman of interventional cardiology at Medanta City in Delhi. Like I said, one of the leaders. He's a Padma Shri and is also a fellow of the Endovascular Intervention Society of India and the Asia Pacific Society of Interventional Cardiology. Dr. Banker is a chief interventional cardiologist and managing director of the Banker's Heart Institute, and he's also an honorary professor of cardiology at the SSG Hospital and Medical College in Baroda. Again, been involved in a lot of trials and has also published in the New England Journal of Medicine. He's also a fellow of the American College of Cardiology and a fellow of the Society of Cardiovascular Angiography and Interventions. The rest of the panel, I mean, the speakers are all my really good friends, and I know for years. So that's great. Dr. Arasi Maran is an associate professor of cardiology at the Medical University of South Carolina. She's one of the few female CTO experts globally and is a well-known PCI expert in the US, regardless of gender. She's facile in all interventional techniques and has been changing how CTOs are addressed in that part of the country. She leads a team at MUSC's Heart and Vascular Center and specializes in advanced hybrid approaches to revascularizing CTOs. And she also is regularly featured in all leading conferences as a speaker, and has been involved in ACC Women in Cardiology and in the Sky Women in Innovation. Dr. Tamam, who will join us about 30 minutes late, he's held up due to an emergency in his cath lab, is an associate consultant interventional cardiologist and director of the invasive cardiology department at the International Medical Center in Jeddah, Saudi Arabia. He's one of the leaders in interventional cardiology and CTOs in the Middle East. He also is an assistant professor of cardiology at the Tokai University in Japan. And incidentally, he's also the founder of IMC Live CTO Summit course that happens regularly at Jeddah in Saudi Arabia. Sanjay Kalra, again, a really, really good friend of mine. He's the first graduate of Columbia University's formalized CHIP fellowship in New York. And is an expert. He also holds he graduated from Canada. He also holds a master's degree in clinical pharmacology. And he is the Associate Program Director of Interventional Cardiology Fellowship at Einstein at Philadelphia, and is the Director of Complex Coronary Therapeutics. Guys, if I missed out anything, please feel free to chime in. It's a great panel and a great list of speakers that we have today. So without further ado, I'd like to welcome the first speaker, Dr. Arasi Maran.
Good evening, I guess. So I'm going to let me start my slideshow.
Guys, can we switch to Dr. Arasi, please? Okay.
Thank you, Arun. Thank you for this opportunity. And today we're going to talk about how to approach coronary CTOs. In this talk, we'll talk about the importance of dual angiogram, how to calculate the JCTO score, importance of maintaining adequate ACTs during your case, couple of case example of an antegrade dissection re-entry in a retrograde case, and then finally we'll put it all together in the hybrid algorithm. So coronary CTO, as we all know, it's 100% occlusion, which is at least 3 months old. You want a TIMI zero flow. There is a donor vessel, which provides the collaterals, and there's a parent or your target vessel itself. Dual angiogram is basically the essential first step. It allows for complete visualization of the proximal and the distal cap. One guide catheter is in the CTO vessel, and the second guide catheter is in the donor vessel. You are essentially using two manifolds. The first injection is for the donor vessel, so the collaterals fill, and then you inject the target vessel so that you can get complete visualization. So this is an example of a diagnostic angiogram. There's an RCA CTO. You can see some epicardial collaterals and some septal collaterals. And this is the CTO of the RCA itself. Okay. Now let's move on to a dual angiographic visualization. This is a dual angiogram taken at the time of CTO-PCI. You can see the excellent visualization of the distal vessel from the collaterals, and you can see the proximal vessel compared to how in the diagnostic angiogram, you could only see the proximal cap. So this is basically demonstrates why you need dual angiogram and why you should use ad hoc CTO-PCIs, because you need time and you need to take time to do all these steps. This is another picture of a diagnostic angiogram. It's a circumflex CTO. LAD has mild disease, and the RCA has phenomenal, robust collaterals going to the circumflex. And you're like, yeah, it's a great CTO. And patient was treated medically for almost 10 years. And then he finally shows up. And this is my first dual angiographic picture. And something just did not feel right with this picture. I felt the plane at where this OM branch was going was awkward. So another picture again of that. And again, I felt like the plane of the OM is not in line with the left main. So it kind of triggered me that this may be an anomalous circ, and I kind of searched for a second anomalous ostium. That's exactly what it was. So there was basically no CTO of the circumflex. It was just an anomalous circumflex origin, and there was a severe stenosis there. And that was treated percutaneously with excellent angiographic results. So basically, this patient suffered with angina and was on medical therapy for almost 10 years, and whereas a dual angiogram would have solved the anatomic ambiguity at any time. So let's go back to the first case. This is another case where dual angiogram, patient was referred for RCA CTO, but the moment we did a dual angiogram, you could see this microchannel all the way through. So it went from a CTO case to just a PCI. So this is how a dual angiogram can change your case. We wired it easily. We confirmed we had another catheter, so we just gave a dual angiographic injection to see where our wire was, and did PCI without any problems. And this is the final angiographic result. So if you try to do a CTO in the absence of dual angiogram, it's almost like trying to drive a car when you're blind. So dual angiogram is essential for CTO-PCI. So let's move on to JCTO score. The JCTO score is basically a Japanese scoring method, which utilizes these four tools. First one is based on the cap, whether you have a tapered tip or a blunt tip. The blunt tip indicates more chronicity, and more chronic the lesion, the more difficult it is going to be. The next is calcification. Even if you have calcification, then you really have to be prepared for advanced high-end techniques and be facile with atherectomy techniques also. And if you have tortuosity, that adds another point. And if your occlusion length is greater than 20 millimeters, that also adds a point. Now, if a previous CTO operator has attempted this lesion and sends it and has failed and sends it to you, that also adds a point to it. And based on that, it's the CTO can be classified as easy, intermediate, difficult, very difficult, and your complication rates goes up as the rates go up. Now let's look at this angiogram and think about the CTO score. This is a LAD and atretic LAD CTO with an atretic lemma. There's a blunt cap, and there's definitely a lesion length of 20 millimeters. You can see calcification again. So this would be a JCTO score, and my plan was to try antegrade, or instead quickly switch to a retrograde option because my cap is ambiguous. So this is the case we saw earlier, the RCA CTO with the JCTO score of 3. In this case, I used a pilot knuckle wire. The knuckle is dancing with the vessel as confirmed by my retrograde shot. And then I set up for a stingray, the stingray balloon. It's in plane. I have to direct my wire upwards. And then this is sticking with the stingray wire. And then this is swapping with the pilot, swapping it for a pilot 200. I'm again confirming I'm in true lumen there. and a PCI as usual afterwards, and this is the final angiographic result. So then my next case is a 49-year-old male who presented with cardiogenic shock. His entire anterior wall was dead. His EF was 15%, but he had ischemia and viability in his inferior and lateral wall. He was initially managed medically for a long time, but he kept coming back with non-STEMIs and angina and CHF exacerbations. So we decided we will take him for CTO-PCI of the RCA and PCI of the OM branch. So the JCTO score calculation here, as you can see, it's kind of a blunt cap, calcification again, and lesion length is greater than 20 millimeters, so we called it 3. The problem in this case was the distal vessel visualization was not phenomenal, unlike the previous case I showed you, where I could, see my distal cap very beautifully and do a dissection reentry. So because of the poor distal vessel visualization, I went with a primary retrograde approach, septal surfing with Xion and a Corsair microcatheter. And then I got to this little point there, and I could not, my usual wires, that is Fielder XT, Pilot 200, Confianza Pro 12, none of it would go through retrograde. And antegrade wire escalation also failed because of a little chunk of calcium there. But thankfully, an Astaro 20 crossed, and I was able to enter into the antegrade guide extension catheter. And clearly, I know there's a calcific nodule. So once we externalized the wire, we did rotational atherectomy with a 1.5 burr and PCI as usual. And this is my final angiographic result. So let's talk about activated clotting time. Regular PCI, normally you maintain it about 250 seconds, but here, if it's an antegrade case, you're doing dissection, reentry, and wire escalation, you want at least greater than 300 seconds. But if you're doing retrograde PCI, you definitely want to maintain it at 350 seconds. And you need to check your ACT every 20 to 30 minutes. Your staff has to stop you. It's a hard stop for CTO PCI. There's no two things about it. And there's no role for bivalvular in CTO PCI because of the amount of gear, and you can't maintain your activated clotting time, so you have to utilize heparin for CTO PCI. Moving on to hybrid algorithm. I know this looks very complicated when you look at it, but actually it is just these 4 methods. In antegrade, wire escalation, antegrade dissection reentry, and if you go retrograde, if it's retrograde wire escalation and retrograde dissection reentry. And in the hybrid algorithm, basically based on the anatomy, you switch. If the distal vessels are appropriate and looking great, then you go antegrade. If you have poor distal targets, you go retrograde and you attempt wiring. If that fails, you move to dissection reentry. And if that fails, you move back to retrograde wire entry or dissection reentry. And it's basically being facile and being not dogmatic, not being married to one particular strategy, but moving through these 4 strategies as the anatomy dictates is the hybrid algorithm. No two things about it. Now let's talk very briefly about retrograde dissection reentry, which is actually controlled antegrade and retrograde subintimal tracking. You have an antegrade wire, you have a retrograde wire. They are in 2 different subintimal spaces. You basically use a balloon, 1-to-1 balloon, and communicate the 2 subintimal spaces so that the wire goes from the retrograde space to the true lumen or the antegrade space into the retrograde space. So this is an example of a CTO PCI. For the lack of time, I'm just going to go quickly. This is basically a CTO of the circumflex and OM. Patient also had a CTO of the RCA, and basically is living off a patent lima to LAD. No retrograde collaterals at all, no visualization anywhere. So as you can see, this is all we get. There's some collaterals, epicardial collaterals from the diagonal. Initially, I tried wire escalation, but I just could not figure out where this wire was. It could be anywhere. I was not comfortable pursuing that because I could not confirm my wire position. So I took a LAD diagonal epicardial with a suo wire and got it into the OM. Then I performed a reverse cart, that is, I put a balloon in my antegrade wire and tried to communicate the spaces. The second guide, which was in the RCA, was essentially useless because there was no collateral visualization. So I got a second left-sided guide, an EBU guide in this case, and used the ping pong technique to get my retrograde wire into the second guide. The wire was externalized, and then PCI was done. And this is basically the complex ballooning and wiring for the reverse cart. And this is my final angiographic result. So this is how it's looked at the end, and this is how it looked in the beginning. So there are a lot of times you hear people say, oh, this vessel looks, there's nothing in it, let's not attempt it. But this is how the wire expands once you have fixed it. So do not underestimate the vessel, and basically look at the amount of myocardium the vessel is subtending and think about CTO-PCI for that. So in conclusion, CTO-PCI, you need all hands on deck. Dual angiogram is essential to understand the anatomy. Be mindful of the manifold and the gear. Manage your ACT appropriately. Pause between the switching strategies that can help the staff to get on board. Have hard endpoints in your lab, radiation exposure, contrast usage, things like the patient's clinical status. In my lab, if I'm not across by 3 gray, then I think about failure modes or just ballooning and bringing back the patient. But each lab has to have their own personalized hard points. With that, I will open the panel for questions. Thank you.
Great talk, Dr. Arasi. Thank you very, very much. She gave a wonderful overview on how to approach CTOs, kind of touched upon the importance of dual angiogram, knuckling, how to use JCTO scores, importance of having a team approach to CTOs, making sure patients getting anticoagulated appropriately, and also not getting stuck in failure mode. So this was a really, really great overview, and in terms of how to approach CTOs. We're going to shortly hear how to minimize complications from Dr. Sanjog Kalra. In the interim, if there are questions, let's kind of take a look at some of the questions and maybe take one or two, and then we'll save the other questions for the end. Okay. I think Dr. Martin's already answered the question about which was the wire that was used in the last case. It was a suo wire with Turnpike LP. For those that are not following it, guys, with Zoom, you can see the chat on the side, so pay attention to that too. I guess we can kind of move on to the second talk. There's going to be a slight change in the schedule. We're going to have Dr. Sanjog take on the next, give the next talk, followed by Dr. Khalid Tamam. He's stuck, like I said, in an emergency in the cath lab. So the panelists, Dr. Chandra, Dr. Darshan, any comments or feedback on the talk that you just heard?
Yeah. I think this was a wonderful, very nice talk. I mean, one of the best talks, I must say, I heard on CTO, very basic. For most of the physicians who are going to start a program or who want to understand, this was really very nice, and I also learned a lot from this talk. And I must say that the cases were also great. I just want to ask one question. Which wire is the suo wire? Because I haven't seen the suo wire as yet.
Suo wire from the Asahi group of wires. So it's a very, very flimsy wire. It has no push to it. If there is a track, it will follow. If there is no track, it will basically curl up on you. And you have to be very careful with the wire, not spin too much, very gentle push, and kind of wait for the systole and the diastole of the heart to let you move the wire. It's also a tricky wire that it can get you into weird spaces where the gear won't follow. So there is a little bit of...
How does it differentiate from the XTAs and XTRs?
Okay, so I feel like the XTs has a little bit of push, or you get a little bit of feedback. Suo, there's not a whole bunch of feedback. So you really have to look at the wire rather than feel the wire and see how the wire is moving, and very gently torque it and move it. Like Shion, this is basically a epicardial wire. It's not necessarily for a septal collateral, but it's more of an epicardial wire.
Okay, thanks.
Can I add something to that?
Yes.
Please do.
The wire engineering of the Suo is fundamentally different than that of the XTs. The XTs are polymer jacketed tapered wires that are meant to engage small channels. The Suo has an Act1 core, so it's a 1-to-1 torque wire, but with a tail wire at the very end, which is a very thin filament of wire that allows it to have a 0.3 gram force tip, so it's very, very soft tip. And that tail wire actually catches bends and allows the leading edge of the wire to curl and move around these types of things. That's why it's so good for epicardials, because the overall gram force is very low. It still has a torque functionality to it, but really what it is it's an inner core that's very light with a tail wire at the front that allows it to sort of swim through these very, very tortuous segments. And so whereas the XTR is sort of designed to slip into segments and use microchannels, the Suo 3 is more designed to take turns and then allow the wire to follow and allow itself to be propelled by the sort of the beats of the heart. It's a very intelligently designed wire, and it feels almost like a piece of thread actually when you look at it.
Thanks, Sanjog.
Yeah, and by the way, Dr. Chandra, it is available in India, has been available, and it's pretty much the default these days for epicardials. So thanks again for an overview of the Suo 3 wire, both Dr. Maran and Sanjay.
I think it's worth mentioning respectfully, and I may be disagreed with in this regard, but I mean, we're talking about introductory basics of CTO PCI. Epicardial
Sanjay, you just froze up.
collaterals are probably not for introductory. Hello?
Yeah, I think we just lost Sanjak for a little bit, but I think the point he was trying to make was epicardials and Suo 3 is not just because it's there. Don't start using it. You really want to be comfortable with retrograde, the steps of it. Really be comfortable with septals before you move on to epicardials is kind of what I think he was getting at. And I think he's trying to log back in. So he is our next speaker. So we kind of, we can, if there are any other questions from the participants, if we can take it. Looks like there's one.
I just want to briefly talk about, reflect on what Sanjog said. I think CTO-PCI is a stepwise approach. You get comfortable with wire escalation, move on to dissection reentry, start with nice septal collaterals, and then your final step or the final frontier of CTO-PCI is your epicardial collaterals. So keep that in mind.
So guys, one of the questions that has been asked is, are there any particular scenarios where you would directly go for retrograde techniques? So Dr. Darshan or Dr. Chandra, or I mean, any of the panelists or the speakers, you want to take that on?
So the question is, yeah, Dr. Banker, yeah, please go ahead. Yeah. Your mic is muted. Mic is muted. Darshan's mic is muted.
Yeah, your mic. He's.
Yeah, so when you have a very blunt thing in the proximal part and like osteal lesion or something, you may straight away go for a retrograde thing straight away. I mean, many times you are not able to even think of doing antegrade. So that is the area where you would consider directly going. And if you have a good collaterals and you are sure that it is better to go through retrograde, it is easier and better to do it. And my question was like, how commonly we should use CT angio for such thing?
So there's some interesting stuff going on right now with CT angiography and actually 3D printing of vessels and heart models to help plan cases. The problem with CT angiography and CTO-PCI fundamentally is that if you don't have contrast flow and through small collaterals, you don't get great contrast flow. And if the heart is any faster than 55 beats a minute, you don't get a good image. And so it becomes quite challenging to actually plan your case. There was a study out of Poland a few years ago that actually used CT angio overlay with Google Glass for operators to try to facilitate their CTO-PCI cases, which was an innovative use of this technology. My personal opinion is that I think it's got a lot of promise. It's very, very interesting, but I don't think it's prime time yet. And that's why the message that Dr. Moran put forth of really, really good dual catheter angiography to do your cases is really critical.
Sanjog, in the interest of time, we are like at 7:30, so do you want to get your talk started, and then we'll save some of the discussion?
No problem.
Yeah. Okay.
Sounds good. This talk has a little bit of panel discussion built in. So, and I'm only going to present 2 cases. So thank you very much, Arun, and to our distinguished panelists for allowing me to to speak to you today. This is, I always seem to get the complication talks. Everybody in the CTO-PCI world knows that I've got all kinds of carnage to show, and so I'm always the lucky one to show all my complications. But I think that they're probably the most important cases for me from a learning perspective. And so my goal in minutes or so is to give you a perspective on how to learn lessons from our cases. I think the only way to avoid complications is to not do any cases. So the key is not to avoid, but to minimize, because we need to get our cases done to treat our patients. These are my disclosures. So complications are germane in CTO-PCI in that they're the primary motivation, other than skill set, to prevent CTO-PCI adaptation across large groups of interventionalists. Why? Because there's a belief of a skewed risk or risk versus benefit balance. There's an issue with operator willingness to innovate in the setting of difficult and more challenging cases. And then, of course, there's a concerning attitude around CTO-PCI complications being serious, and the complications of just symptoms untreated with patients only on medical therapy being a better course. But we know that as we iterate our skill sets, as we get better and better at what we do, our complication rates go down and our success rates go up. So when we think about complications, we've got to think about them in some sort of construct. And so I propose that we think about them as the so-called forest versus the trees. If you can think about looking at a forest, you see the entire group of trees, you see the trends, you see the large sort of areas that require treatment or that require consideration. But that's very different than the trees, which are the fine details of what we do and what we know. So what do we know? What's the forest of CTO-PCI? Well, based on the Progress CTO registry, which is a large US registry, MACE rates are about 3% in CTO-PCI. If you look at some of the other registries, either in Europe or in Japan, where they treat less post-CABG patients, those numbers are slightly smaller. If you look at Open CTO, which is an NCDR audited registry, it's slightly bigger. But the reality is the majority of complications are perioperative MIs or tamponade requiring pericardiocentesis, probably because of perforations. And when we look then at these data from Rob Riley and his group out of Open CTO, we see that the risk of any complication in this NCDR audited study is about 10%, which is pretty high, 1 in 10 people. And these are expert operators, keep in mind. The death rates are quite low, about 1%. But once again, the rates of cardiogenic shock and the rates of perforation are about 9%. The number of perforations that require treatment are still relatively small, but it's important for us to understand that that's an important thing that we need to look out for as operators. That's the forest, right? And the predictors of those things, that's what the forest tells us, where the grand scheme of things are advanced age, the use of retrograde techniques. We had a question about retrograde CTO-PCI. The reality is retrograde techniques are germane to success in CTO-PCI. We have to have them, we have to use them. The key is being good at them and using them when they need to be used and using other techniques when you can use them. And then of course the JCTO score, and understandably, as we get more complicated, we get more chances of complications. The thing is, the study, the forest, is not doing the case. How do we as operators prevent complications? How do we figure this stuff out? We have to examine ourselves as systematically as we examine our data, right? So this is a construct of how to consider complications, whether it's in CTO-PCI or not. Oops, sorry. The first thing you consider is the predictability of the complication in the context of the case. So whenever we look at CTO angiograms, when we consider our pre-procedural plan, we think about the various approaches that we're going to use. And thinking about the data that we know from the forest, the things that predict complications, we can consider the risk of complications for our individual cases, and that allows us to be prepared. And this is probably the most important piece. It's not the event or the move that leads to the complication that's important. It's the move that led you to make the move that led to the complication. So for example, if you have a perforation in a vessel because you oversized the stent, it's not that you picked too big a stent based on the angiogram that led to your complication. It could be that you had a big knuckle, or you had extensive calcification and you went up too high because you were worried that you didn't atherectomize, or your case was getting long and so you didn't use intravascular imaging. That's the event prior to the event that led to the complication. That's the behavioral piece that we need to identify and we need to change. Of course, the treatment that we employ and the outcome that we achieve is important in understanding how we manage and minimize complications. And then most importantly, what are the lessons learned for next time? What are we going to do differently to make sure that this doesn't happen again? So let's go through a couple of cases. This one's a 59-year-old female with a past medical history of coronary disease with CABG in 2008 and a previous PCI to the circumflex. She has HFpEF, hypertension, dyslipidemia, type 2 diabetes, and she has bad peripheral arterial disease. So this predictability piece should all be starting to run around in your head, right? This is somebody who's going to have bad disease and who's going to have lots of calcification. She's had less FA stenting, and most importantly, she's got end-stage renal disease. And we all know that these types of patients are higher risk for bleeding, they're higher risk for perforation, they're higher risk for all of these types of things. She presents with worsening angina, and she's found to have a right coronary artery CTO with an occluded SVG. So there's another predictor, right? She's post-CABG with documented inferior wall ischemia and documented viability. So let's show you the angiogram. So you can see that this is a fairly long CTO. You can see that the vessel is outlined before we get any contrast in, so there's significant calcification. Here's the old vein graft here that's now occluded calcification that you can see along the vessel. So we started with antegrade wire escalation. We got a turnpike LP and a pilot 200, and you can see that that's the pilot 200. And despite that miserable CTO, this is how long it took to cross the whole thing. That's it. Not that hard, right? So you can be lulled into a false sense of security by thinking this was a pretty quick CTO and I have my wire across. There's proof that we're in the distal lumen. This is the old vein graft down here that's sort of feeling a little bit retrograde, but is occluded. Certainly as a retrograde conduit, that recanalizing that vein graft might be a reasonable option. But it's okay, we're across. The problem is the calcium, right? So we have difficulty with stent delivery due to tortuosity and calcification. You can see that there's a guide extension here. There's a wiggle wire down in the artery now, and we're having troubles. And look at this. Look at how much this artery is bending, right? Ooh, did we see that? That was a frank bend, a frank change in the arterial wall where you can see that with pushing, and you'll see that in a second with pushing, we have a true disruption in the wall of the artery. So now you've got a dissecting perforation. Now, there's a lot of things that have gone on wrong here, right? There's an antegrade injection happening when you have that kind of disruption. The operator that did this case asked me for help, and it was immediately after this dissecting perforation had happened. And so in my case, I didn't have very much time to review the case before I understood what I was getting myself into, but this was probably the biggest concern that I had, right? So now that you have a dissecting perforation, what do? Well, typically in the literature, we know that intramyocardial hematoma as a result of these types of dissecting perforations that go into the myocardium. These patients do poorly because they have tremendous hemodynamic compromise as a result of compressive effects of the hematoma that's within the wall of the myocardium. So quickly, we tried to reduce flow into this. We put a prolonged balloon inflation up, a covered stent deployment. The patient briefly required fluids and vasopressors. We did an interprocedural echo, and this is what we saw. This huge right atrial hematoma that was sort of abutting the tricuspid valve annulus, right? This was compressing the area within the right ventricle as well. And so you start thinking to yourself, this is probably going to behave like a tricuspid stenosis type of phenomenon. But interestingly, the patient remained relatively stable with minimal vasopressor requirements and intermittent atrial fibrillation. And so this is one of those examples of where the forest tells us only so much, because this experience as an operator is clearly different than what I would have expected. So after prolonged balloon inflation and a very gentle injection to document that there was no more movement, further stenting was performed. We optimized the proximal part of the vessel, and these were our final results. Not bad, not great, but not bad. So questions for the panel. Was this complication predictable, and if so, how? And how might you have managed this problem?
So, Sanjog, I think it was a very aggressive use of wire. In general, if I have to use a wiggle wire after a CTO case, after I've crossed a thing, I think about atherectomy. I would have thought about rotational atherectomy much
That's right.
earlier. Even with the 125 bird, I think might have saved the day instead of wiggling in a CTO.
Particularly when you don't have any dissections. And so that's a really important point, right? What is it that led the operator to make the decision to push the stent? Why it's a problem that the stent bent, but what is it that led the operator to make that decision? It's because they thought that putting a wiggle wire down in the artery would be enough anchor to get the balloon, to get the stent across, not recognizing that even if you get the stent across in a calcified, horrible artery like this, you're not going to get a good stent result. And so atherectomy is really your only choice in this type of scenario. That's an important
lesson. In this case, Sanjog, can I ask you one thing? Mm-hmm. When the stent was being pushed,
certainly,
whether adequate ballooning was done before that or not? Do you have any, pictures of that?
So that's an excellent question. I don't have the pictures. What was taken to pre-dilate this vessel was a 3.0 NC balloon at 20 atmospheres, and that balloon expanded.
It expanded.
So interesting, right? Yeah, you would expect that the stent would go. The problem is that calcification is not uniform, right? It's in multiple different planes throughout various parts of the artery. And so even though a thin, easily delivered balloon will go and expand because the adventitia will distend, as you can see, this adventitia was very distensible. The problem is that even when you get a stent down that doesn't flex as well as a balloon will, you're not going to get a very good stent result. In this case, with this dissecting perforation, they didn't have to do atherectomy because the vessel was completely disrupted. So that's obviously not an optimal scenario.
Again, I think the fundamental message is like making sure you got good vessel prep before delivering the stent. So Dr. Banker, now let us say you were in this situation and something has happened. At this point, is there something that you would want to do?
I was worried that the delivering stent was also a difficult thing in this. Delivering a covered stent would be a much more difficult proposition. And many times we just have to leave this vessel and forget it. Keep it chronic as a chronic and just forget it, right? And save the life of a patient. That would become more important rather than achieving an egoistic result of putting a stent and getting a result in this case, because we already had created a lot of hematoma. Personally, if given a choice with such a picture, I would like to close this vessel rather than keeping it open and micro leaks happening and patient become deteriorating with a myocardial hematomas, because you don't know the hematoma may still continue when you have angiographically not seen hematomas. Okay, so it was good that we were able to deliver a covered stent in this case. Otherwise, just leave it. It is many times very difficult in a calcified tortuous vessel to deliver a covered stent. That's what my feeling is.
I think, that the operator was actually moving ahead in the right direction. If he was able to dilate a 3 millimeter NC balloon at that site, then taking a stent was reasonable. And trying to push it was still, it just happened that he was pushing harder because he knew that the NC has already dilated, the stent will go. But this is something very weird which happened primarily because of that wriggle wire. Otherwise, if it had been a all-star wire or a more support wire, it would have been better. Or taking that is hindsight. Basically.
Yeah, I think the problem here was just the nature of the vessel, right? Yes. But your point's very well taken. And this is what I want the audience to take away from this. You see two experts on the panel and they're saying exactly different things. And that's where the trees come in. That's why we have to study our own experience as operators very carefully in order to prevent CTO-PCI complications. Because how many cases in the literature are published that look like this? How much data are there in the literature to create a forest out of these kinds of cases? There aren't very many. And that's why forums like these, honest procedural sharing and a systematic way of analyzing these cases is so important. So I'll move on just in the interest of time. The post-procedural hemodynamics, because these patients they get quite sick, we got post-procedural hemodynamics right away. And it really didn't look that bad. The right atrial pressure was high, right? That's slightly concerning because obviously there's some compression of the right atrium, but the RV was fine. The PA was fine. There was RV competence. The mean PA was 28. The patient did have a history of pulmonary hypertension. The pulmonary capillary wedge pressure was 12. The output and index were reasonable. And so when we got a CT scan post-procedure, we saw this huge hematoma. It was 2.3 by 2.3 centimeters. But interestingly, the patient kept saying, why are you keeping me in hospital? I want to get out of here. She was completely hemodynamically stable throughout the entire stay. She had intermittent atrial fibrillation. She was started on a NOAC, but ultimately she went away, right? At 72 hours, this was the repeat CT scan. It was quite stable. And 1 week post-procedure, this was the transthoracic echocardiogram, right? And you can see that there's a little bit of resorption happening to that hematoma, but it's certainly still there. Ultimately, the patient refused to come back for more CTO PCI because she said, I feel great, I have no more chest pain, right? So the lessons about intramyocardial hematoma and dry tamponade, these are variable clinical courses. There aren't that many that are published in the literature, but it's certainly a complication that we know can happen. And the signs and symptoms seem to depend on the compressed structure and the degree of compression. If it's the left atrium or pulmonic vessels, sometimes you can get pleural effusions or pulmonary edema, like in the MS type picture, versus the right atrium where there's supraventricular arrhythmia, sometimes atrial fibrillation, sometimes not. And then the really troublesome ones end up in the RV wall or the LV wall, and in particular in the septum in the LV outflow tract, where you can create a true obstructive type picture. Those patients end up in serious shock. It's very important for us to get hemodynamics early to be able to monitor these types of patients and be able to tailor our therapy. So in the case of an LV, for example, with a big intramyocardial hematoma and either compression or edema with a lack of flow, that's when mechanical circulatory support or things like ECMO come in. And our partnership with our surgeons is also truly critical, though in these types of situations, generally there isn't much to remove because the hematoma is within the wall of the heart. A non-contrast CT is also helpful to fully define the lesion. And so when it comes to the perspective of dry tamponade and how to manage it, right, the sort of management algorithm, certainly you stop the recanalization attempt if you can, right? In this case, because the covered stent was in and we were worried that in this case, you do want to close off the flow into that hematoma so that it doesn't get bigger. In this case, we chose to put the covered stent in because I think it was very important to do that. You do the balloon occlusion, you do the fluids and pressors, you get the hemodynamics and consider support, and then you watch them very, very carefully because the mainstays of management in this situation are supportive. So what were the trees? What did we take away? Perforation risk is predictable given the tortuosity and the calcification, but not the intramural hematoma. That happened because of pushing. And so the decision not to use atherectomy, over-aggressive equipment delivery, and antegrade injection strength were the problems. Those were the events that led to needing to push the stent hard and causing this complication. And so the supportive treatment was sufficient, thankfully, and imaging and hemodynamics were truly key to help understand precisely what to expect and how to manage the scenario. And the lessons, the advice for next time. Hemodynamics are critical in these cases, as is the location of the hematoma, but treat the patient, not the picture. This patient was kept in hospital for almost a week by non-invasive cardiologists who were just uncomfortable with what they were looking at. Whereas as CTO PCI operators, we do have some evidence and some experience with this type of a complication. And this is the type of individual who was at 72 hours completely stable, on a repeat look angiography completely stable. And so that's the type of patient that can be carefully monitored as an outpatient. So let's go on to the last case, this LAD CTO. This one is my case. These are my hands. Gives me nightmare still, but it worked out okay, as you'll see. 52-year-old female, past medical history of coronary disease, diabetes, hypertension, with a baseline blood pressure of 220 to 240 as a result of a pheochromocytoma. She's pending surgery, and so she was sent for preoperative risk stratification in this setting. She has class 2 angina at baseline and a big anterior area of ischemia and hypokinesis. This is her angiogram. So what we see here is that she's got a very proximal, essentially ostial LAD occlusion with virtually all of her flow. We see that virtually all of her flow is coming from the distal septals from this very tortuous RCA. So you know now that when you put a wire down this thing, you're going to end up straightening out a lot of this vessel, and you may end up causing more ischemia because you're going to create pseudo lesions, pseudostenoses. Left system here, as you can see, you've got multiple vessels, but it's really difficult to determine what vessel comes off. You've got a ramus in the middle, you've got sort of an accessory ramus, you've got the circumflex. And so you'll notice that I have a safety wire down the circumflex because that's a retroflexed vessel and it's probably the most difficult to wire. And that's an important lesson that I've learned from previous analysis, right? Recognizing that safety wires in your donor vessel system are important because donor vessel complications kill patients. So in this case, despite thinking that this was going to be difficult. You can see the real-time retrograde wiring with a Corsair Pro and a Xi'an Black. This is basically a full circle, as you can saw. It was a full loop, and up we went into the septum and up towards the proximal cap. This was really straightforward, much easier than I would have expected it to be, but hey, we'll take it. So now here comes this wire proximally, and you can see that it's sort of on top of the left main there, but now we've got a retrograde wire. Now, how do we get this case done, right? This is, as it comes up forward, it's not puncturing the proximal cap, it's, you know, burrowing in behind the left main. Now it's retrograde, right? So we're not that worried, but there's a little burrowing of that wire. And so we obviously don't want to push it forward because we don't want to injure the left main or dissect it off. So how do we deal with this? Well, we tried IVUS guided proximal cap puncture. The problem was that the left main and the carina was so large, it was almost a 9-0 vessel that we were unable to see onto the other side of the vessel with an IVUS to be able to puncture antegrade. So instead, we decided to use this wire retrograde, right, as your marker and try to puncture antegrade. So you can see this antegrade wire right here, trying to puncture retrograde, or trying to puncture antegrade through the proximal cap using that retrograde wire. The thing is that retrograde wire is pulled right back into the microcatheter, right? It's not really a huge loop. It's just a tiny little marker. It's a tiny little target. So now that we can't puncture the proximal cap antegrade, now what do we do? Well, we get an angled microcatheter, right? And we'll put the IVUS back in and see if we can identify the proximal cap, use the retrograde wire at the same time. And with that angled microcatheter, a supercross, let's try to push forward. Now, once again, this lady had, on the clinical side, she had anesthesia present for this case because the first time we tried just getting wires into the RCA, she didn't tolerate it from an ischemic perspective. And because she was quite large, we had serious radiation and contrast issues. And so we were trying to move reasonably quickly. Once I called for the angled microcatheter, I thought to myself, let's weaken the proximal cap, right? Let's do a retrograde Carlino, and let's try to weaken the proximal cap so that it'll make it a little bit easier to cross. And so I did a retrograde Carlino. And what you see now, as I'll let that play one more time, I injected from here, and you can see that contrast is now all the way out here. So you can see contrast all the way out into the aortic root with that little bubble. So what we've done now is actually actively retrogradely dissected using contrast all the way out into the cusp. So this is a big problem, right? And at this point, the patient's blood pressure goes from 220 to 90 systolic in about 10 seconds. Panic. And this is the angiogram. Every vessel off the left system is gone. Circumflex, the ramus, even that little lip of that accessory ramus is gone.
Looks like there are some streaming issues right now. So, I mean, while we wait for Sanjak to get back on, I mean, Khalid, you kind of saw this case. Well, first of all, welcome. I hope that patient is okay. I know you had an emergency, so thank you for joining. Really appreciate it.
Yeah, thank you very much.
And so, I mean, we have a great panel now. So, Khalid, what would you do? I mean, you're a retrograde expert. So at this point, what would be your first reaction?
Actually, you know, it's always happened to us when we have this ostial, very close LAD or circumflex close to left main, to deal with the left main. And when you get a retrograde wiring, always we have to take care about donor artery, about the left main itself. So now we have to survive the patient. So I will stand directly left main circumflex, yeah, just to secure the patient. So that's the first option to do, just to open the left main circumflex to just get the patient get back to the life. Stabilize the patient. Your retrograde wires get well. While if you stand the left main circumflex, 80% the patient will come back. 80 to 90% will come back.
Right.
Maybe you need intra-aortic balloon pump, but this will take time. But the most quick thing to stand left main circumflex. Maybe after you stand the left main circumflex, the carina will be modified, and will be more easier to puncture the distal cap to the LAD. The problem now with the 3-branch you lose, because sometimes you close, and this is really trouble. You know, it's I think now he has to open the left main circumflex and then to open the 2 arteries until the patient comes back.
I'm still having a
but It happened to me twice.
Uh-huh.
I stabilize the patient and I continue the CTO. I don't stop the procedure because the problem in this patient, you already spend a lot of time to do the CTO through these epicardium collaterals. So the patient already tired. So whatever happened to him is crashed very quickly. So we need to stabilize him. So always I recommend not spend a lot of time in epicardium collaterals because you tire the patients. Because sometimes we spend 3 hours, 4 hours, more, and patient is already tired. So what you do, Arun, in this case?
I mean, I would concur. I mean, you got to restore flow into the circumflex. Now, whether just ballooning is going to restore it, or if you need to stent it, and you're right. Sometimes stenting does help modify it to get back antegrade. It's always a problem, as you said, when you're so close to the left main. But I would love to hear what some of the others have to say before I kind of chime in. So, we have Dr. Chandra and Dr. Banker, again, two super experienced interventionalists in India, and of course, Dr. Maran from Charleston. So yeah, I mean, would love to kind of pick your brains. Dr. Chandra, what would you do with this situation?
I think, I agree with Dr. Khalid and you that we have to stent and maintain some flow immediately. And that's the only way to do it. But other than that, I don't know what we can do before we go ahead. So certainly there will be some set of people that will say that, okay, once the patient is stabilized, just hold on and then bring the back patient again after some time. However, if the patient stabilizes quickly and there is no other arrhythmias and he's not needing too many angiotropes, I will go ahead and do it. So I'll assess the situation before going ahead and doing this procedure. But I completely agree with both of you. Yeah.
I have an idea. I mean, my idea is to tell that whenever we are doing a high-risk PCI like this, involving left main, I would prefer to have another catheter through radial rather than the femoral. So we have another femoral access available for assisting device, like putting an ECMO or IBP available straight away. For anything, for hemodynamic support, you need it. You need that access clear. And we can always use radial in such cases for another catheter to be pushed. So I would prefer, when we are planning such CTO, especially left main CTO, when it is criticality is there that you may have a hemodynamic collapse and you have to put an assist device, then to keep another femoral spare would be a better idea. What is your thought?
It looks like Sanjog's back, so let's kind of see what he did. And Dr. Maran, unless do you have anything to add at all, or?
I think it's pretty, I mean, all of us agreed that we have to rescue the left main. So let's see what Sanjog did.
Sounds good.
I would like to mention something that Sanjog, I think he put 2 wires, so he's ready to just balloon the patients, and resuscitate the patient. So from beginning he put the 2 wires in the circumflex and the branches.
I mean, I think that's always a prudent thing when you have the osteal LAD CTOs, right? I mean, always protect, and you got to be super careful when you're, doing any kind of aggressive maneuvers. I mean, the one thing is knuckles may be a little bit more controlled than injecting retrograde Carlino. And it's one of those dictums again, right? When we stent people, I think almost everyone on the panel is going to use a guide extension before they start, playing around at the proximal LAD.
Okay.
Sometimes seen. Okay, good. Well, Dr. Sanjog, welcome back.
So so far we've dissected the left main off. She has no blood vessels left anymore. That's not good, right? So I heard some of the conversation that was about whether or not the complication was predictable and how much.
Or maybe Sanjog can just tell on, just vocally.
Yeah, do you want to just fill us in without, it's okay if the pictures don't show. Sanjog, if you want to just tell us what you did.
So let's go to Dr. Khalid's talk.
Yeah, so
this time
let's switch to Dr. Khalid Tamam, and then we'll come back to Dr. Sanjog.
Okay, so it's short time. That's always Arun gave me the short time to prepare it. Just one night. So I think it's a lot of audience has been familiar with that. What I will tell now, but I think it's just a refresh for what we are using every day. So always when we are thinking about a CTO, I think it's coming in our ideas or our mind. What's the toolbox we have to use? I don't know, in India or in other place in the world, and in Egypt, in Middle East, in some place, we are always thinking about the economic and always how to success in less material. Because sometimes you success in the CTO, but you're gonna get zero pay. So you have the bill come to you from the administration and tell you, okay, great work, but you have to pay from your pocket. So it's very good to familiarize what you have to use, what tools you have in your cath labs, and how to get success rate higher with these tools. So as we know, that's we have not very specific CTO tools. We have to have it, but wires is very important. Microcatheter is very important. Guideliners or guidezilla or whatever mother and child technique catheter, you have to have it in your cath labs. Snares, rotablators, laser, the gears for the perforations. As now Carl, he has a perforation, so you have to not do CTO high risk procedure without being in very equipped cath labs, because you may need umbrella, assist device, and if you do it standalone or without backup surgery, you may lose your patient. I know Arun is very familiar to travel around and working in very unequipped cath labs. But sometimes when we have troubles, we are stuck because we don't have the material. Before we supposed to take all our when we do proctoring or we're going to do another workshop in CTO, we have to take with us all the guide equipment, including the guide wire, microcatheter. So if the audience hear us now need to start the CTO program, you have to have this equipment in your cath labs. So first of all, we have to be familiar with guide wires, and when we use antigrade or retrograde strategy, we have some tools of guide wires we have to be familiar with, including a Sahi guide wire, which is, for me, it's the best wires I use, and usually now I'm using 3 wires only or 4 wires. So my wires always, now in my own practical, I start with a Felder XTR. Then if it's not work, because sometimes I need to puncture the very hard CTO cap, so I move to harder wire, which is Gaia 2nd or 3rd. If it's not work, Confianza Pro 12. And if I have some tortuosity, sometimes value 150, 200, it's in. So that's all. But if you have much experience, you will see that these guide wires sometimes work. So here the requirement of CTO, it's a tip profile of the wire is very important. So you have to know how is your guide wire is working. So it's a tip profile of the wire is very important. And if you work with the wire, you know how is this, it's kind of going, if it has a micro channel or not. Torquability of the wire, you have to be very knowing of this your kind wire, you have a good torquability or not. Penetrations. Sometimes from beginning, if you have a stent occlusion, for example, so if you have any stent occlusion, for example, no need to use a Felder XTR because it need a hard wire from beginning. So we need to have a penetration wire. So going direct to have a harder wire. So stenosis is a very important that to know that it has a microchannel or not. Length of the occlusion is important to identify your guide wire. Tortuosity, calcification, and bifurcation. So this are 4 items we have to have it in our mind all the time when we are working to TTO. And this, all the wire we are using to do, I think there is some of them still not used anymore, like Miracle 3. There is, I don't know anybody still using. For me personally, I don't use. Confianza Pro 12 became because I think, or the case has been referring to us, and now it's the harder cases. So it's mandatory to use, we are frequent user Confianza Pro 12. Then filter XTR, not XT, but XTR. FC not anymore using now. Pilot 200, 150, and Pro 9, Pro 12, Pro 20. So this the scheme of the wire we are using right now. And this is a filter. We have to know that the filter tip is 0.9, how much the long of radio opaque part, and the diameter of the tip. We have to know it as well. So this kind of short segment with maybe the plaque is not so hard and there is existing microchannel, the filter XTR can going very smooth in this kind of lesions. So don't be afraid that this kind of lesion is difficult and need a harder wire. As much as you have a CT scan or patient is not very heavy calcified, sometimes the filter XTR is going smooth. And usually I'm using the filter XTR, and I said if the wire don't make loop, it's mean you are in the true loop. So if you are going in any of these collaterals, it will end by loop because it will going to the loop. Or if you go to subintimal, it also ends the loop. If it's going straight, filter XTR, you are in good. So try to go as much as you can with the filter XTR. And if it's sometimes, but the drawback of filter XTR is very soft wire, so it's very easy to broke, and you may use 2 or 3 to continue your job. So sometimes you need to upgrade from the filter XTR to Miracle or to something hard wires. And this is success rate of filter XTR in the G scores during the this is XT in the last period. So I escaped from filter XTR and I'm going to another wire. So we have to go next step if we need more wired, which is penetrating wire. So Miracle now, as I tell, the Miracle is already has been not used anymore, but Miracle Pros or Ultimate Pros, it's very, I don't know, you have it in India, Arun, or not? Hello, I don't hear you.
Yeah, I'm sorry. Which you're talking about? No, we don't have the UB3, but the Miracle series we do.
No, but Miracle Ultimate Plus, you have it, yes?
No, UB3, no, we don't.
Yeah, UB3 is a very unique wires, which is have a hydrophilic coating, which is now it's especially when you have a retrograde penetration from retrograde, the Miracle UB3, it's wonderful wire, which is can be very easy to get your job. Again, Confianza Pro, it's very important to have it in your cath labs. And the tip load of the Confianza, it's 0.9. And then if you go to more to Confianza 12, its tip load is 12 milligram. And then we can upgrade to 20 and 40. I don't know you have 40 or not, but it was in existing in Japan, the 40. And sometimes they are using, I don't use it here, but sometimes tip load in 40 in the very heavy calcified, both dialysis patients or patient with any stent occlusion. Sometimes you have a 3 stent, and this is very difficult to go by any man, except the very high tip load. So I skipped this one also. Okay. Again, what we have in the, if we are going with a retrograde wiring, so you have to secure in your cath labs a short guiding. It's very important to have 80, or you will cut your guiding, and you are always in the risk to do guiding by your hand, and you are in the risk all the time for tortuosity. Your guiding, sometimes perforating, sometimes broken, so you are always in the risk. So usually short guiding is better. Sometimes you have a 90 centimeter guiding or 8 centimeter guiding. It's very important. Usually here I'm doing bilateral femoral, sometimes bilateral radial or femoral radial. The most easier according to you when you have. Important to have an external wire. RG3, it's very important to be in your cath labs if you do retrograde. So the guide wires is very important to have external extensions. As I tell you, the guideliners is very important to have in your cath lab as well. I'm sorry, let me go a little bit. Yeah. It's very important when you are doing with such a CTO cases, because we are speaking the tool, you have to have guiding externalizations and the tool to help you if you get troubles. So very important. Sorry, I'm just skip this. I'm sorry, Arun, to not well prepare the this is a microcatheter. Usually when we skip the wire guide wires, then we go to the microcatheter. It's very important for us to know the microcatheter, what we have to use. If you're using a bilateral radial and you're going by a 6 French, so usually here I'm using a microcatheter fine cross or Corsair Pro 12 or Corsair Pro, I know in USA they are using more with the vascular solutions, American tools like LP or the same microcatheter. But here I'm using always a Corsair Pro or Garavel or Fine Cross microcatheter. The important to know that sometimes these tools cannot go with 6 French. So you have to know that tool, it's sometimes bulky and you need to have a 7 French or 8 French to make your setup it's complete when you start. So here's the example of the Corsair Pro, which is have a very good torqueability, and a tip also it's very easy and not harmful of the collateral. And how it's Corsair Pro can going in acute angle. It's easy to go comparing with the Corsair. So this is one example of the microcatheter, which was always used to do a CTO. It's mandatory to have this kind of microcatheter. So let me skip also the, this also you have to know that some microcatheter should be visible in your cath lab, especially if you have a very obese patient. So this all the microcatheter torqueability and structure of the microcatheter. So also, as I tell you, it's very important in the toolbox, mother and child, or guideliners, or Guidezilla, or the one from Medtronic, the new one now they have. Always you have to have it guide externalization. It's very important to help you, especially if you see the previous case, he may use it to have a guide externalizations. It's better than to have to dissect the left main. Sometimes it's help you. Also, the WM microcatheter is very important. Sometimes it's help you to puncture the bifurcation lesion. If you have a bifurcation PCI to CTO, it's very good to have a double human microcatheter. Also will help you to during your work. Laser is not using anymore, but sometimes for instant occlusion, also using laser. Sometimes it's used. I don't know. It's not available here, but I know in the States they are using laser in sometimes of the kind of the patients. So again, it's some indication like uncrossable lesions, impenetrating cap, instant occlusions. It's very useful to have it there. Reverse cart is question mark, but again, the laser complication is heroic. So you have to be very expert with laser. Otherwise, if you get a perforation in close to left main, you will perforate in the left main, so you lose one of the arteries. So it's very important to having the laser. This very important toolbox, you have to have it in your cath labs. I never do any proctoring in any place in the world without having coils in my pocket. So always, I believe that I have to have coil in my pocket. Otherwise, if you get a perforations and you cannot deal it. Sometimes the perforation is huge, and you don't have surgery, and you are in the cath labs which has no enough equipment. So coils is very important. So stand graft coils, the tools of embolization is very important. Pericardiocentesis kits should be in the in your cath labs. Sometimes echo. It's very important also to identify if the patient has tamponade or not. Again, this is a preparation type, and this kind of tool of coils we should have. And you have to be familiar. Cook coils, Medtronic coils, so the coils, whatever coils you have to be familiarized with. And you know that not all these coils can work with our microcatheter we are used. So you have to change the microcatheter with bigger human microcatheter to use this kind of coils. I will give you one small example of perforations. I don't know you have it or not, but this one of the case we're doing, and it has been CTO of the RCA, and very easy. This is a microcatheter we are using. This is a Crocea Pro 12, which is a nice tip, and you have a tip injection, very good connection, but it's very tiny. So we go by filter XTR and then going with a Crocea Pro to the tip of the RCA. And then stenting the RCA, very easy. So reverse with a very reverse card. The procedure was not difficult, but when you finish, before you finish up the procedure, you inject to the donor artery to see if you have trouble or not. The patient was hemodynamically stable, but if you see it here, when we inject the left system, you see that there is some kind of perforation. You know what? This kind of perforation is usually closed alone, but you never know. Patient, if you spend 2 hours in this procedure, he gives a heparin of like 20,000 heparin. So you don't know what's happened after 2 hours or 3 hours if you leave the patient in the ICU or the floor. So maybe the patient tamponade. So it's secure. It's better to be secure and to close this this kind of perforation. So it's again, you change the microcatheter with a maybe bigger microcatheter, bigger lumen, as you see here. These are with a trauma microcatheter, fine cross, and you put the cook wires and close. And check again, it's closed. Sometimes you need 3-4 wires. Here we open the RCA, and you have almost 4 coils to close this septal channel. And it's not nice to end up with this kind of perforation and this kind of coils. But I think it's familiar with all of you as an expert of CTO. Familiar with this picture, always you have it. I think if we go to after your cath labs, we see a lot of your patients like this. Anyway, double lumen microcatheter, as I told before, this is very important to have it in our tools, and like Kasky, like twin pass. So always, sometimes help us to get a true lumen, and especially sometimes we use a reverse wire techniques, and it is very important to know this kind of techniques by double lumen microcatheter. I think this one is not working. So this kind of example of reverse wire technique, I think it would not here, but give you a brief how to do it. This you have to use a wire like a Felder XTR or a Pilot 50 or Pilot 150, this kind of hydrophilic wires, and you make it as a loop, and you put it in this in the microcatheter, WMA microcatheter, and just you advance, and when you pull it back, you penetrate the angle. The angulation is very important to be like a 45 angulations, not 90. And sometimes it's work and sometimes not, but it's working in the soft black with difficult angulation to get it by usual wire. So the example again of reverse wire techniques. Okay, so important also to have in your toolbox snare. A snare is very important. You should have it in your toolbox, and it's very important to know it, how to use it. And I think all of us know, but I speak about the audience. They are seeing us now, because I think one of the case of retrograde case, if you do it, sometimes you need to have the snare to put your wire to donor catheter. So there is a lot of kind of snare. We have to use it, and it's available. So we have to use how to do this kind of snare. And it's also a cheaper way of snare. That's Dr. Samituji from Japan has been mentioned before. I don't know you know it or not. And it's very, very easy one. It's just to put a balloon in the wire in the catheter. You are do it before you inject the catheter, and you loop the wire, and just you loop the wire and you inflate the balloon inside the guiding, and just you push your wire in one direction, and then when you snare it, you just catch it. And this is a cheaper way of the snare. So I think this is the all we have to use it in my talk right now. This kind of the snare, it's supposed to be used. That's all. I think this is the end. I have to end my talk.
That was a fantastic overview, Dr. Khalid. I mean, the key is, as he said, especially when you go to other labs, is to know what is available and what is not. The one other thing that I think he's just alluding to now is making sure you know, in some labs where it's available, keep the Stingray balloon catheter. But the key is to be prepared, and I mean, especially for complications. In fact, by the way, guys, I kind of said that, and someone on the chat, I don't know if you've been following, stand corrected. So UB3 apparently is available in India. I always thought it was left over by the Japanese when they come for proctoring. Like Sasuke at times is available in some labs, but it's not technically available in India. You always get it from the Japanese when they're here. So there, thank you very much, Dr. Khalid, for that fantastic overview. I think Sanjog's back and he claims not to have internet issues, so I'm just going to give him 5 minutes to wrap it up. And then maybe we can just have a discussion.
So as Khalid pointed out, the first thing that I did in this case was rapidly stented from left main into circumflex. And I stented into the circumflex because I had the safety wire in, because that was the most angulated branch. That was the one that I was most likely to lose because of the dissection. You can see that there's some flow now right after I've stented the circumflex. So we've tamped down a lot of that intramural hematoma, but there's still limited flow. So ultimately what we ended up doing was using IVUS to define precisely where our intramural hematoma was and how best to figure out where to stent, what would need to be stented. You can see these sort of pictures of intramural hematoma coming up on the IVUS. There's some calcium there that you see, and then there's really, really bad disruption of the vessel that you'll see momentarily. There we go, right underneath here. So you can see the large intramural hematoma. So we had reduced flow in the ramus after the PCI, and so we ended up getting a wire into that ramus by recognizing what side of the vessel the intramural hematoma was on. Used a cutting balloon distally within that intramural hematoma to pop it. And this is the IVUS coming back from the ramus into the left main. And you can see that there's that intramural hematoma at the bottom, but that There is now some connections between that and the left main. This is still there, and so it tells you that you're going to need to have some more stent deployed somewhere to tamp this down and preserve flow. The key, however, was to avoid further injections and understand where the trouble is.
And are there any questions that have not been answered? I mean, I guess there were a couple of questions. There was one question about cart versus reverse cart. I think Dr. Maran has already answered it. And there was lots of questions about what's available. There are some questions about the different kinds of microcatheters. So in general, I mean, I think the overarching message is to be prepared when you are starting a CTO program, especially if you're going outside to another place. In general, also know what you want to, how do you want to approach these CTOs? I think Dr. Rasimaran gave a great talk on that. Sanjog has really told us how to try and minimize complications. And Dr. Khalid has kind of given us the hardware. So let's kind of see, I mean, in your experience, I mean, I think Dr. Chandra and Dr. Banker, you've been in India for the longest period. So I would say, what are your big challenges that you guys see in terms of CTO PCI in India? Like, I mean, especially in terms of the challenges, why do we not do as much as in the West or Japan?
Okay. So let me start. Darshan, you want to start or should I say? Maybe I'll start. Okay.
Yeah, I think he's muted. So.
Yeah, he's muted. So anyway, so the thing is that, you know, in India, as you have seen, that interventions have grown quite a lot. And we are doing more than 500,000 to around 700,000 interventions. It's expected that we will be finishing this. Now, the point is, why not too many CTOs? Because in CTOs, the materials which are going to be used are unpredictable many times. And we expect that in most of these cases where you have to finish finally, a lot of wires and a lot of things will be used. So which brings the cost of this procedure exponentially high, much higher than a bypass surgery. So whenever a bypass is possible, because bypass in India is very cheap. And you know, compared to anywhere else in the West, the cost of bypass is how much? Maybe maybe just $2,000 to start with, and then usually in private hospitals about $4,000 to $5,000, compared to CTO angioplasty, which may go much beyond this. So that is why this is the issue of less usage of CTO angioplasties in India. That's my feeling as far as this question is concerned. And the second is that, we started doing it with the Japanese. The Japanese used to come, they used to bring their things. So the availability of stuff was also like leftover products we used to use. But then now more and more products are being available. We are using it, and people are also getting, in more insurance and more support to get these procedures done. So it has increased. In the last, I think, few years, CTO angioplasty has improved.
So I just want to make a comment on the cost. People think just because we're in the US, we get access to all the material and we have a free open supermarket of CTO equipment. I work in the Veterans Hospital, which is pretty much like a government hospital, and the budget is ridiculously tight. So when I look at my CTO cart, I make sure every wire has a purpose, every microcatheter has a purpose. There's no plus ones and me too catheters. So you can definitely tailor your CTO toolkit to be like absolutely essential and still be successful.
Absolutely. I totally agree with Dr.
It's probably
Marcy. Yeah.
Yeah, it's worth recognizing that these things, a lot of these things are Me Too devices, right? They do exactly the just as she mentions, exactly the same thing. And the skill of the operator comes down to choosing the right device for the right scenario, right? So not all wires are created equal. Not all microcatheters are created equal. Make sure you understand the tasks that each piece of equipment is supposed to perform, and then have one piece of equipment that you know inside out, backwards, and upside down on your toolbox that performs that task. There's no need for repeats then.
Absolutely, Sanjog. The problem here is that in many cases, at least I will say more than 50% cases, you cannot just say that I have chosen this and this is the right wire or the right.
Yeah.
You may end up finally using 5 wires and 10 balloons. So that is why I'm saying that was a limitation. with many of the Indian operators at that time. But now you are seeing that the use of Fiddler XT wires, the Gaia family of wires have increased exponentially. The Conquest Pro wires, all of them are being used in so many numbers, which means not many cases are being done.
Guys, two things. One, I think we are kind of running short of time. So those people, just to be respectful of other people's time. So if people need to leave, please go ahead. Really appreciate it. Just want to give this concluding statement from Promed Hospital. Thank you very much for each and every one of the panelists and the speakers, Dr. Praveen Chandra, Dr. Banker, Dr. Arasi Maran, Dr. Tamam, Dr. Sanjag, for your valuable time, and for each one of the participants for having taken time during these. I mean, I know there are lots of web conferences going on right now, so really appreciate it. Tomorrow, join us for an anti-grade session, same time. Hopefully, we'll not have so many technical issues. It's again 7 to 8:15, but it can go on till 8:30. So all of you are welcome to join. I'll send out the link. It's actually on the PDF document itself. So those that need to leave, please go ahead. And if there are any other questions, I'm going to just stay on for a little bit longer. Happy to stay around.
Thank you.
Thank you very much, Arun. Last question. They sent me a question to which cover stand we have to use. I think it's all is using the stand of graph stand from Boston or from Guiding before. I think now it's a Pantera stand. It's okay. You have to know that before, if you are dealing to have a CTO centers, you have to have this kind of very low profile graph stand, because sometimes the lay vessel is very calcified, very small. So you have to have this kind. I don't want to mention stand to other because I know there is a conflict of interest to the company. So, but there is a lot of stand, cover stand, and many of them, they are low profile, and you have to know that this your profile, low profile one. The last thing, I have also question coming to me here about the guiding catheter. The microcatheter is very important to know also before you start, because sometimes people, they would like to be fancy and using bilateral radial and using BASICS French, and going to have a microcatheter which is not compatible. And when you go to do trapping, you are stuck because the balloon cannot go together. So if you go by ipsilateral techniques, or you go to using a one guiding catheter, you should go with 7 French, 8 French, not 6 French from beginning. So it's sometimes it's very small thing, it's logic thing, but it's important.
Absolutely. Which, mind you can also do through the radial. You can do 6 French, you can do 7 French, you can even do 8 French through the radial. It's just a matter of knowing how to put it up there.
Yeah, but the important, when you're using radial and using left system, you be careful with like XP to hurt your left main, because sometimes it's the angulation from radial, it's traumatic. So always you have to, because as you are expert now, but we are speaking about the audience who's maybe the first time using, and they and he just take care about retrograde. Antegrade donor artery is dissecting the artery because it's going from radial. Very simple. Huh?
I mean, I think that the presence of a safety wire there is important, but the reality is radial PCI, regular PCI, is pretty commonplace now, and across most of North America, people are quite experienced with radial access and radial guide engagement. I think good guide habits, big guides going into the left main, you should always be careful, right? You should always have safety wires down donor vessels and these kinds of things. And when taking larger guides, your point's well taken that sometimes you've got to be careful of the size. And what we have found is that if you take in the radial scenario, the left radial to engage the right coronary, the right radial to engage the left coronary, you end up with reasonably good back wall support, and you can always use guide extension catheters to extend things along with active guide support. And that allows you a little bit of freedom from banging your guide into the left main if you're going retrograde. It protects the vessel a little bit, as does the guide extension, because it's a bit softer.
Yeah, I'm absolutely agree with you. Some question also came to me now about basic cath labs and doing CTO. Before I was working in the very basic cath labs, and when I was in Egypt in National Heart Institute, and they are doing in every day like a 60 to 80 cases per day. So and I shift my case to make the end of the day, like a midnight, do CTO, which I'm not recommended. Is not a good idea at all, because you are tired, your team is tired, and your patient is tired and fasting from early morning. And the most complication happen in the midnight. So I'm not recommended anymore to do it. I do it this before, but if you are in basic cath labs, please ask your teams to dedicate 1 or 2 days for you in the week to do the to CTO.
So
And
to be
do it
honest
in
with you, Dr. Khalid, and some of the other folks, I mean, I think in India the challenges have also been. I mean, people touched upon cost, people touched upon being busy, but the reality also was there was a certain level of comfort factor. Like, I mean, you had traditionally some experts come in and do CTOs, and it was always like the holy grail, and it was one of those elitist things that a few people are going to do. And the other thing is, like, increasingly people get success rates, and then they don't want to fail. And I think one of the most important things with CTOs is you are going to fail at times. And I think that's a key thing that people have to know. And doing what's right for the patient. So, like, that's always been a big challenge, I think. And the cost factor now with the stent pricing having come down significantly, it kind of, I think, has leveled the playing field a lot. I mean, our stents here are less than $400. So you could do definitely single vessel CTO PCI can be done. I mean, you can beat cabbage. I mean, I've now been doing stuff here in various hospitals. You don't have the luxury that you have in the US, but it can be done. It definitely can be done. Especially we have a lot of patients post cabbage. Lima is open, rest is all gone, or Lima is gone. I mean, what are you going to do now, right? So I think it's about education, and thankfully, I mean, I think having experts like you and others join us and educate, and I think this will help. I think this will help a lot.
Yeah, I think so.
So guys, like I think we are running really short of time. So I think we still have 60 participants, but unless there are any other outstanding questions, I'm sure Dr. Khalid probably he wants to get back to his patient there. So any other questions, or I'm going to wrap it up shortly, and let's join again for tomorrow, 7 p.m. Look forward to it, guys. Thank you, Dr. Khalid. Thanks, really.
Thank you very much.
Thank you, everyone, for having joined us. Really appreciate your joining us. Thanks a lot. I'll see you tomorrow.
Thank you. Goodbye.
Bye-bye.